Okay, well, thank you everybody for joining us today. This is a session brought to you by the GAP, MASLD, and MASH Community Network, where our unified goal is to provide evidence-based resources to enhance your clinical practice with all things MASLD and MASH. So my name is Tessa Janovsky. I am a PA at Arizona Liver Health here in Phoenix, Arizona. This is the QR code to record your attendance. So we'll just keep this up for a few seconds here if you need it. Okay, so today we're going to be talking about the MASLD basics. And that starts off with the new nomenclature. So non-alcohol fatty liver disease and non-alcohol steatohepatitis is no more, and the new nomenclature is MASLD and MASH. And this really, this was a long time coming. This was started basically it was with a global Delphi consensus process that was co-led by MASLD and EASL. And they worked with, this involved various different national hepatology societies, patient advocacy groups, spanning over 50 different countries. And the purpose of this, it was designed to address some of the limitations that to the terms of NAFLD and NASH, including overall the exclusionary nature of the diagnosis and potentially stigmatizing language. And so, and overall, the lack of recognition of what truly the root cause of the disorder is. And so they came up with the overarching or umbrella term of steatotic liver disease. And so metabolic dysfunction associated steatotic liver disease, or MASLD, has replaced NAFLD, and metabolic dysfunction associated steatohepatitis, or MASH, has replaced NASH. We still have our alcohol-associated alcohol-related liver disease, and the new component of steatotic liver disease, which I think was very much needed, was this term called MET-ALD. And so this includes patients who have MASLD, meaning that they have fat on the liver and they have cardiometabolic risk factors, but they also they have an increased amount of alcohol intake. And so this, while there are pretty precise cutoffs in this area, but clinically, this can represent a pretty wide spectrum. And so within this, you can see that there can be patients who are more MASLD predominant or also more ALD predominant if they fall more on the right side of this chart with more alcohol intake. And then there still remains the other specific etiology, steatotic liver disease, the drug-induced liver injury, monogenic diseases such as Wilson's disease or LALD, the lysosomal acid lipase deficiency, and then the miscellaneous, which would be hepatitis C, celiac disease, malnutrition, those types of things. And so basically this was chosen, steatotic liver disease was chosen to classify individuals with hepatic steatosis due to various etiologies. So looking specifically at MASLD, this is the presence of hepatic steatosis and any of these 5 cardiometabolic risk factors. And again, if there's no other cause contributing to the steatosis. So looking at this, you basically would find hepatic steatosis on imaging or biopsy, and then you ask, does this patient have cardiometabolic risk factors? If yes, and if there's no other causes of steatosis, then they would be classified as MASLD, or metabolic dysfunction associated steatotic liver disease. If additional drivers are present, that would be a combination etiology. So, for example, if somebody has MASLD, but they also have autoimmune hepatitis, this kind of opens up for multiple or combination etiology. How will this change affect your practice? To be honest, it won't. There's been various overlap studies between MASLD defined population and the historical definition of NAFLD population, and they found overlap, a near complete overlap between these populations, including one, the natural history of these patients, and also biomarker validation studies are basically showed that identical overlap of these patients. So aside from changing the verbiage in your EMR, there really shouldn't be any change into how you diagnose these patients or treat these patients. Taking a closer look at MASLD, again, hepatic steatosis with any cardiometabolic risk factors. So they need to have at least one of the 5 cardiometabolic risk factors. That would be BMI over 25 or increased waist circumference. And this is adjusted based on ethnicity. So that BMI is going to be lower for our Asian patients. If they have type 2 diabetes or a fasting glucose greater than 100, or if their A1C is greater than 5.7, if they are being treated for high blood pressure, or if they are not and have a blood pressure greater than 130/80, and then if they are on any lipid lowering medication, or if they have triglycerides of greater than 150, or if their HDL is low, then that would classify them as MASLD. And again, this excludes patients with alcohol consumption. And so basically, if a patient drinks, for a female, if they drink more than 1 drink a day, or men more than 2 drink a day, this would exclude them in the strictly MASLD, and they would probably fall more under the MET-ALD category. So if MASLD is suspected, what is the primary care management of these patients? A lot of times this happens in the clinic where you have an ultrasound that will say hepatic steatosis. And so from a primary care standpoint, what's the next step? So the biggest thing is to conduct a primary risk assessment, and FIB4 is going to be the recommended risk assessment to start off with. It's very easy to calculate. It includes age, platelets, AST, ALT, which are routinely obtained during a routine labs. And so if the FIB4 is greater than 1.3, then an additional fibrosis assessment would be needed. If it is not, if your FIB4 is less than 1.3, then we can reassess in the future by doing additional FIB4 testing. For patients who have prediabetes or type 2 diabetes or greater than 2 metabolic risk factors, they really should be checked every 1 to 2 years because they are going to be at a little increased risk of fibrosis over time. For a patient who has no type 2 diabetes and does not have greater than 2 metabolic risk factors, that time frame will extend a little bit every 2 to 3 years. And so again, if their FIB4 is greater than or equal to 1.3, we need to get an additional assessment. And so the recommendation for additional assessment is going to be VCTE, which is basically a FibroScan, or a ELF test, or enhanced liver fibrosis test. If they show up low risk in these, which is if their KPA on the FibroScan is less than 8, or their ELF score is less than 7.7, they would return back to primary care, and you can reassess later. If they fall into the intermediate or high risk category, they should be sent to hepatology to identify and further manage these patients who we believe are at risk, who have at-risk MASH, or possibly even cirrhosis if their FIB4 is greater than 2.67, excuse me, then we would be worried about cirrhosis. So in the specialty clinic in hepatology, if advanced fibrosis is suspected, again, if any of those tests comes up in the intermediate or high risk of fibrosis, then we basically will determine if they need to consider a biopsy. If we need to consider a biopsy, technically the gold standard still for most accurate fibrosis assessment is going to be a liver biopsy, but with our great NRTs, we try to avoid that unless it's necessary. And so we can do other things in the specialty clinic, like get an MR with elastography. We can repeat fiber scans, things like that, that we can better assess these patients. And so if we find that they are at low risk or in their stage 0 to 1, we reassess in 2 to 3 years. If they're in stage 2 or stage 3, we definitely reassess them at least annually. And then these patients, we would consider pharmacotherapy on them. Since we have new pharmacotherapy, we definitely want to catch these patients to try to avoid them from progressing to later stage liver disease. And unfortunately, those patients who turn, if we find are stage 4, then our management switches. It switches to cirrhosis-based management at that point. Why is this so important that we risk stratify and we try to find these patients early? Is because fatty liver is super common, as we know, or MASLD is super common. This is taking a look at the global epidemiology. And so you can see the numbers here. In North America, on average, 31% of patients will have MASLD or be classified as MASLD. And that ranges from 25% in some studies to 37% in some studies. The rates are even higher in Latin America. But across the board, you can see pretty staggering numbers, and why it's so important that we have ways to risk stratify these patients. Looking at the natural history of MASLD and MASH, so of the up to 80% of Americans that have MASLD, about 15 to 20 million of those will have MASH. And over 20 to 30% of those patients will progress to fibrosis in just over 3 years. And why this is so important is because fibrosis progression is pretty significantly slower in patients with MASLD than it is MASH. In MASLD, it's about 14 years to progress to fibrosis stages. In MASH, that decreases to 7 years. And 20% of those patients are what we classify as fast progressors, which means that they could progress to cirrhosis in just 10 years. And so, early identification is crucial, but can be difficult. And some factors or predictors have not been fully quantified, but if somebody has a higher ALT level at baseline, any sort of family history of cirrhosis due to MASH, or if they have the presence of diabetes, they definitely could fall in that category of faster progressors. So 20% of patients in stage 3 will progress to cirrhosis over a matter of a couple of years. And once with cirrhosis, they're at risk for liver failure, liver death. 30 to 40% of patients with cirrhosis will pass from their liver disease. And ultimately, hepatocellular carcinoma is a risk for patients with MASH, not just MASH cirrhotic patients. We've seen episodes or cases of HCC in patients with MASH who don't have cirrhosis. So it's very important that we screen our stage 3 patients as well, because they are at a little bit of an increased risk. So over time, as far as progression from MASLD to then we have F1 to F3 and cirrhosis, and unfortunately HCC, we've had an increasing number of what we call single nucleotide polymorphisms, or SNPs, that have been linked to MASLD. The biggest one, the most well-known one, would be the PNPLA3 mutation. And so we know that environmental and non-genetic factors may amplify the genetic risk that is conferred by these polymorphisms. For example, adiposity or obesity heightens the risk of liver disease associated with PNPLA3, and also concurrent alcohol use can have a significant effect as well in these patients, as far as progressing to later stage fibrosis or even cirrhosis in a much shorter amount of time. And then as MASLD and fibrosis worsen, gut microbiome becomes less diverse. We see higher abundance of streptococcus and gram-negative bacteria, which also has been shown to possibly affect these patients and cause them to progress even faster. So the key takeaways here is that MASH with F2 to F4 fibrosis is what we consider as at-risk MASH. These are the patients that are higher risk for liver-related events and mortality, and again, why we need to locate these patients early. The rate of fibrosis progression and hepatic decompensation depend on what the disease severity is at baseline. It depends on individual environmental factors, genetic variation, and also comorbid disease. And so patients with MASLD without advanced fibrosis, they're most at risk for cardiovascular disease and non-hepatic malignancies. But unfortunately, in patients with advanced liver disease, death from liver disease is the predominant risk of mortality there. Let's talk about a patient case. So this is a 55-year-old male. He was referred for elevation in his aminotransferase levels. He had right upper quadrant discomfort. He's gained weight, 20 pounds over the last 5 years. His liver chemistries were mostly normal over the past 5 years. He's had some mild intermittent elevations. And so looking at his labs, mild increase in ALT 45, AST 50, normal ALP and total bili. These, sometimes depending on the lab that you get the labs from, these will still be in normal range. But we know that we want those liver chemistries, the AST and ALT, we want them in the teens and 20s if we can. And anything more than that to us is an elevation. He's got a past medical history of obesity with a BMI of 35, weighing 230 pounds. He does have prediabetes and hypertension, no family history of liver disease, and a rare alcohol use. And he works in IT, so likely a sedentary job there. And he's on lisinopril for high blood pressure, but doesn't seem like he's on anything for prediabetes or weight loss. And when on exam, he has that central obesity with a waist circumference of 110 centimeters. So looking briefly at steatotic medications and other etiologies. So as far as medications, we know that amiodarone, methotrexate, and tamoxifen are typically the most common that we see that can cause increase in hepatic steatosis and over time lead to fibrosis. Corticosteroids also in our patients with rheumatological disease, that they have to be on long-term steroids. They're definitely at risk for steatosis on the liver. And then briefly, the additional etiologies of hepatic steatosis, which would be Hep C, Wilson's disease, malnutrition, celiac, among others. So patient evaluation, when we see a patient in clinic, we always say that the elevation in liver chemistries due to MASLD or MASH is a diagnosis of exclusion. So we want to make sure that nothing else is going on or nothing else can be contributing to this inflammation in the liver. And so we order viral hepatitis serologies. We'll order ferritin and iron studies. Of note, ferritin levels can increase in patients with fatty liver. It's one of the most common causes of mildly elevated ferritin levels because it can elevate with inflammation, cellular damage in the liver. So it's important to look at that iron saturation level before we order any sort of genetic panel for hemochromatosis. We're going to do autoimmune markers, check for other metabolic liver diseases. We'll get the basic CBC, CMP, INR, check his synthetic function. And then he has metabolic disease, right? So we want to check an updated lipid panel, hemoglobin A1C. PEP test is something to consider. I think that's being used a lot more recently because we just never know. And alcohol use has increased definitely since the pandemic. And so it's just another piece of information to the puzzle that can help us see if there's any other cause of hepatic steatosis here. Of note, one thing that I wanted to mention is that the ANA and smooth muscle antibody, ASLD guidelines and multiple studies show that up to 30 to 40% of patients with MASLD can have a weak positive or weak titer, low titer positive autoimmune serologies without an overall clinical picture of autoimmune hepatitis. So if you sometimes we'll see patients with a smooth muscle antibody of 1 to 20 and they're sent over to evaluate for autoimmune hepatitis, but we know that that's likely related to MASLD rather than true autoimmune hepatitis. So so that is something important to note when you are reviewing this workup. As far as imaging, we did an ultrasound. It only detects moderate to severe hepatic steatosis. So back to our patients, the ultrasound showed an increase in hepatic echogenicity with regions of focal sparing. The contour of his liver appears smooth and his spleen is normal in size, which is important because those are going to clue us in on if there's any evidence of cirrhosis or portal hypertension. So at the end of the day, hepatic steatosis, no evidence of portal hypertension. Which patients still need a liver biopsy? So we always still have a liver biopsy in our back pocket if we feel that we need to, in any patient. Some things to consider is if you have non-invasive markers that are indeterminate or discordant, you have a FibroScan showing one thing, an MRE showing the other thing, and you really want to get a true fibrosis score, then a liver biopsy can be considered. And also just to rule out concomitant liver disease. If they have a high titer of a smooth muscle antibody, for example, and really high liver enzymes, then we need to rule out autoimmune hepatitis as a cause. So it definitely is still a role for it, but be very careful in who you select to biopsy and make sure there's a good indication for that. So back to our patient. So he definitely falls in the MASLD criteria. He's got hepatic steatosis on imaging. He has metabolic risk factors, and there doesn't appear to be any other causes of steatosis. So we can safely classify this patient as MASLD. So next, the primary questions to ask is, does this patient have underlying MASH? Does this patient have any fibrosis? And does this patient have advanced fibrosis? And that's where we talk about the non-invasive testing that we need to do on this patient to see if he do a FibroScan, see where his fibrosis is, and if we can get him on some medication. He definitely has risk factors, cardiometabolic risk factors such as obesity and prediabetes, almost diabetes. So talking to him about GLP-1s and that sort of thing. So basically, sorry, skipped ahead. So once you've classified a patient as MASLD, the next step is to really risk stratify this patient to see if he is in that at-risk MASH category. And if he is, then we need to be really aggressive with how we go about his management and treatment and possibly get him on some pharmaceuticals. So thank you so much for attending. There's more podcasts to come to kind of answer these questions and go more in depth on how to with NITs and pharmaceuticals. So make sure you check out the other podcasts that are available on the GAP community network. And again, thank you so much for joining me today. You can scan this QR code to visit the GAP MASLD MASH community network and for more disease state education. And there's also a ResDiffra promotional program that you can take advantage of. So